with cerebral palsy, growth, puberty, and possible pitfalls. So what I want to do is talk a little bit about normal growth and puberty, growth in cerebral palsy, normal and abnormal puberty in cerebral palsy, bone health, management of pubertal problems, and finally to answer any questions you may have. So thinking then first about normal growth. Well, this is Karlberg's infancy, childhood, puberty growth model, which describes growth from birth up until cessation of growth at the end of puberty. And it's divided into 3 phases. Infancy, between birth and 2 years of age, which is mainly determined by nutrition and insulin. Between 2 years and the onset of puberty, the childhood phase, is determined largely by growth hormone. And then we reach puberty at the age of around 11 to 12 years, when we have the pubertal growth spurt determined by growth hormone and sex steroids. And it's the sex steroids that ultimately cause the cessation of growth with fusion of bone, stopping growth. So genetics accounts for 70 to 80% of linear growth. Also important is nutrition, hormones, growth hormone, thyroid hormone, and sex steroids. And finally, psychosocial effects. So individuals who are abused, perhaps emotionally or physically, do not grow as well as their healthy peers. Assessment of growth. How do we do this? Well, measurement of length or standing height, measurement of body weight and head circumference, plotting these onto growth curves, and looking at longitudinal growth so that we can determine how quickly or slowly that young person is growing. We can compare their current height with their mid-parental target height to see whether they're achieving this or not. And finally, we have an independent measure of growth and maturation with bone age taken from the left hand and wrist and analysed usually with an atlas or a more computerised version. So when we're measuring standing height in children, we use a Harpenden stadiometer or similar. The child should be barefoot, remove all hair ties, and they stand straight with their feet flat on the floor and their head positioned in the Frankfurt plane. The headpiece is then pressed down gently on top of the child's head and a measurement can be taken. In babies and toddlers who do not stand reliably, the measurement is of length using a measuring pole, head and foot piece. The child's head is placed against the headpiece and then both of the child's feet placed against the foot piece with the feet at 90 degrees to the legs and the toes pointing straight ahead. Not enjoyed by these young people. And then we can plot these growth measurements, these height measurements, on a centile chart, such as shown here, which is a chart for boys between the ages of 2 and 20. And there are a number of lines on this. The heavy grey line in the middle is the average line, on this 50th centile, and the limits are the 97th centile, the tall ones, and the 3rd centile, the smaller ones. And if you're below or above these limits, then you are deemed to be potentially abnormally tall or abnormally small. But if you look at those, you can see that 6% of individuals will lie above or below, and not very many of those will actually be abnormal. So when we're assessing a child's growth, we want to know, is this child's size within normal limits for his age, his sex, his population, and the parent sizes? And then secondly, has this child's rate of growth, so how fast they're going over the past year, been within normal limits for his age, sex, etc.? And we do this by comparing the height with the age references and using our centile charts and comparing those height standard deviation scores with the target height standard deviation scores, probably seen more easily on visually on those charts. And then longitudinal analysis of growth, i.e. the height velocity, is taken and once again can be compared with age references. And how does this work in practice? Well, we've got two different growth trajectories shown here. On the left, we have weight at the bottom and height at the top. And this child's weight and height have been plotted regularly over the last few years. And we can see that from the ages of around 3 until 7, he has gained weight and grown normally. And then following this, his weight has accelerated, so he's gained weight rapidly, but he's hardly grown in height at all. And the sorts of problems that we may be thinking about here is hypothyroidism, or more rarely, Cushing's syndrome. In the chart on the right, we have a child being measured really quite frequently. They're below the 3rd percentile, but you can see that they're growing parallel to it, i.e. their speed of growth is normal, at least until they're around 12 or 13 years of age, and then you can see a rapid acceleration of growth over the next few years until this child reaches a final height between the 25th and 50th centile. And a classic example of this in a young boy would be constitutional delay in growth and puberty. So moving on then to puberty. What is normal puberty? Well, the definition is it's the transition period from the sexually immature state to the potentially fertile stage during which secondary sexual characteristics appear. And during this time, we have the development of secondary sexual characteristics, the adolescent growth spurt, the accumulation of bone mass to reach peak bone mass, and psychosocial and neurocognitive changes. Secondary sexual characteristics are driven from the pituitary gland, which itself is governed by the hypothalamic axis and higher centers than that. And we're looking in the girl on the right with breast growth, menstruation, changes in her body shape, and the development of underarm hair and pubic hair. In the boy on the left, we have voice changes, the development of body hair, the enlargement of the testes and genitalia, and the onset of spermatogenesis. So this is just summarized in this very simple diagram here, initiating puberty from the pituitary, governed from higher centers, the hypothalamus, and higher centers further than that. Pituitary giving rise to FSH and LH, or follicle stimulating hormone or luteinizing hormone, acting on the ovary to produce estrogen, which then acts on estrogen sensitive tissue to allow the pubertal changes. And there's exactly the same changes in the boys, but obviously acting on the testis to produce testosterone. A normal puberty in boys starts at an average age of 11 and a half to 12 years. And the first sign is a testicular enlargement with changes in the scrotum and penile length. This develops further with a continuing increase in testicular size, further development of the penile length and breadth, changes in the scrotum, and the onset of pubic hair. The adolescent growth spurt in boys starts about a year after the onset of puberty and reaches a peak at about 14 years, i.e. it is really quite late in this process. When we look at staging puberty in boys, we use Tanner staging, which was originally derived back in the 1950s and looks at between stages 1, which is prepubertal, to stage 5, which is complete adult. And we're looking at a number of different factors: the size of the testes, the presence of pubic hair, and how the scrotum and penis are developing. If we look at normal puberty in girls, we see a slightly different scenario. So girls start puberty on average at the age of 11, with the first sign being breast development. But as soon as they're showing the first signs of puberty, their growth rate is already accelerating. The start of pubic hair occurs 6 months later, with a peak height velocity at around 12 and a half, 13 years, with menarche occurring at 13 years between mid and the end of puberty. Tanner staging in girls, once again, stages 1 to 5, 1 being prepubertal, 5 being fully mature, and this is based on breast development and pubic hair development, with menarche occurring somewhere between stages 3 and 4. So thinking about puberty and its effect on growth, we've got girls starting puberty at average age of 11, but any time between the ages of 8 to 13, with an average age of menarche at 13. Boys starting puberty at an average of 12 years, but with a range of 9 to 14 years. So these are 5 years variation, and a growth spurt with an average of 14 years. And what this amounts to is the contribution of puberty to the individual's final height is 30 centimetres in boys and 28 centimetres in girls. That's 17% of their final height. So a very important part of the growth process. So moving on then to consider those with cerebral palsy. So what is cerebral palsy? Well, the definition is a permanent movement and posture disorder that limits physical activity and is acquired around the time of birth. It can be prenatal, perinatal, or early postnatal. But what we see is individuals with significant movement problems, but it may also affect their speech, their swallowing, their vision, and some of them will have learning difficulties, but by no means all. And what we can see with these 3 children here with different varying types of cerebral palsy, the little boy on the left, we can see that he looks very cheerful. He's got a convergent squint. He's in a especially adapted tricycle. You can see that he's very well supported. He's almost having to keep his hands on these handlebars. On the right, we have a little girl. She's got, you can see perhaps that her hand is hyperextended. She's likely to have a rather more athetoid type of cerebral palsy. She's needing a lot of support for her head. She's got bands around her chest and her hips, and she's in a standing frame, trying to allow her to get some weight bearing. And finally, the lad in the middle, he's in a wheelchair. He's got his head turned to the left. He's got a feeding tube in place, head needing support. And you can see that he's been placed in a very good position with his legs, his ankles bound in the correct position. And he's got ankle, foot, knee orthoses, trying to keep his feet in a good position without the development of contractures. So what we can see from what we talked about earlier was how we measure children is we can see in this scenario that it's going to be extremely difficult to get an accurate measure of either height or length in these individuals. But despite that, there's some published data about them which show that they tend to be lighter and shorter than their peers, with being 5% shorter than their peers at the age of 2 and more than 10% shorter at the age of 8. And the etiology of this slow reduced growth is multifactorial, but it's likely to include poor nutrition and possibly abnormal growth hormone secretion. So this slide here shows quite an old study from 2006 of centiles for boys with cerebral palsy measuring their knee height. So this is from obviously from the ground to their knee, not allowing for, obviously making sure that they haven't got contractures. And the top chart shows these measurements being made in boys with cerebral palsy of different ages with the centile lines constructed for them. And then the chart below, the graph below, shows this same centile charts for cerebral palsy boys, their knee height, with superimposed knee heights for healthy boys. And you can see that up until the age of puberty, healthy boys have greater knee heights, but there is some overlap. But then they reach puberty and these accelerate away so that they diverge and they are significantly taller than those with cerebral palsy. So thinking about nutrition in these individuals, we've already said that they may have difficulty in swallowing, chewing their food. So a study of gastrostomy feeding in 57 children with cerebral palsy by Rempel et al. Found that over 90% of them were below the 5th centile for their height and weight before they were gastrostomy fed. After 18 months of gastrostomy feeding, 33% remained underweight, and by now 21% were overweight for their height. However, there was very little increase in their linear growth, although there was an improvement in their general health. So thinking a little bit more about the role of growth hormone, we know that children with cerebral palsy have an abnormality of their central nervous system, and we might there anticipate that some of them will have abnormal growth hormone secretion, which will impact on their growth. And a study by Coniglio, SS et al. In 1996 showed that 6 out of 10 children with cerebral palsy and poor growth had abnormal growth hormone secretion. So I just want to present a case to you who presented to us really quite a number of years ago now, but he presented to our endocrine clinic at the age of 11 years with short stature. He was born following a concealed pregnancy to a single 16-year-old mother and was adopted at the age of 10 months. He had a left hemiplegia, cortical blindness, and constipation. And his adoptive mother noted that he was both growing very slowly and that he never seemed to age. He always seemed very youthful. And then on examination, he was pale, he was thin, he had nystagmus, he had a left hemiplegia, he had facial and general asymmetry, and was prepubertal. His height in the clinic at the age of 11 was just 106 centimetres, -5 standard deviations below the mean, and he had a bone age delay of about 5 years. And in view of this, he was investigated for his short stature and was found to have growth hormone deficiency, and he was started on treatment with growth hormone. And this chart here shows his centile chart. I apologize for the poor quality of this, but you can see the bottom line and point at the age of 11 years shows his height in comparison with the normal centiles. And the dotted line shows his bone age at the age of 6 years. He was then started on treatment with growth hormone, and you can see that his growth rate has increased. He's catching up with the centiles. His bone age delay is reducing, and by the time he's 18, he has reached the centile chart and largely finished growing. So what I want to talk about here really is that when we have a child who is clearly growth hormone deficient, we have to think, what are we treating them for? In those with cerebral palsy who are being managed by carers who need to be lifted up, moved around, who may have to try and move themselves, is it in their interest to be particularly tall? Well, the issue here is that growth hormone deficiency doesn't just affect growth. It affects your fat-free mass, your muscle strength, your muscle development, your bone mineral density, and has very important metabolic features in addition. So although we may not really be looking for these individuals to becoming very tall and large, it's still very important when we've identified growth hormone deficiency to treat them appropriately. So what about puberty in cerebral palsy? What are the issues here? Well, during puberty, we've already said that we're going to have an adolescent growth spurt. We have perhaps seen from that graph showing knee height that perhaps that doesn't happen so well. Sexual maturation, so the development of secondary sexual characteristics, when does that occur? Is it early or late? And what about increasing bone mineral density? And then on the personal and social front, particularly a feature in girls is management of menstruation. And many families are very unhappy about their daughters with cerebral palsy having to progress through puberty and start their menstrual periods. There are also issues around sexual function and contraceptive issues. So puberty in cerebral palsy, we know there's an increased incidence of true central precocious puberty. So puberty occurring well below the ages of 8 in a girl or 9 in a boy, often very early, 3 or 4 years. In girls and boys as well with cerebral palsy, not necessarily fully precocious, but we find that puberty tends to begin earlier in these individuals, but ends later. So that full pubertal progress, which already lasts for a number of years, lasts even longer. So in girls, they may start puberty at the age of 8 or 9, but the average age for menarche is 14. And finally, puberty may also be delayed, so just not really occur until after 13 years in a girl and 14 years in a boy. So a case now, Jordan, he was a boy who presented at the age of 3 with the early growth of pubic hair. His primary care physician thought his genitalia also looked large for his age, but his general health was good, although he was quite tall. He'd had normal development, except there'd been some concerns regarding his right leg, and at the age of 3, he was still falling very frequently, and he had rather difficult behaviour. There was no family history of precocious puberty. And on examination, he had testicular volumes of 4 to 5 mils, i.e. suggesting that he was in early puberty. And this was also confirmed by Tanner staging of pubic hair stage 2 and genitalia stage 3. He was also noted to have an abnormal gait. He was dragging his right foot. Height and weight were on the 75th centile. There were no other signs, and he was clinically euthyroid. Investigations using a GnRH, a gonadotrophin releasing hormone test used to determine whether we have central precocious puberty, showed an LH predominant response rather than FSH predominant, indicating true central precocious puberty. He had a testosterone value of 11.2 nanomoles per litre, equivalent to a low adult male's testosterone concentration. He had a normal prolactin, normal thyroid function tests and liver function tests, negative tumour markers, but his MRI scan, which was originally reported as normal, was reviewed and found to show subtle periventricular white matter volume loss, i.e. cerebral palsy, or the sort of CNS abnormality that we would find in those with cerebral palsy. So what we have here is central precocious puberty in a boy with newly diagnosed cerebral palsy, so something to just be aware of. I just want to talk now a little bit about bone mineral density in children with cerebral palsy. Children with moderate to severe CP have smaller, thinner bones with reduced bone mineral density compared with their peers. And a study by Henderson et al. In 2002 of 117 children with cerebral palsy showed a reduction in bone mineral density in the distal femur in 77% of them. So a huge number. And fractures in 26% of children occurring over the age of 10, most commonly of the femur. And the reasons for the reduced bone mineral density in this group is multifactorial. So we know that they've got poor nutrition, including both poor vitamin D and calcium intake. They've got an abnormal bone muscle unit, so their muscles don't move their bones very well because they've got spasticity. So they don't have that continual movement of bone as determined by muscle unit. They may be immobilized either long-term or temporarily, strapped to their wheelchair, for example, because you're protecting them from falling, or temporarily perhaps because they have a fracture. Low estrogen and testosterone, perhaps because of delayed puberty or iatrogenic, because it has been thought that really this young person isn't going to be best helped by going through puberty, and also growth hormone abnormalities, which we've already mentioned. Many of these young people will have epilepsy and be on anticonvulsants, which will also affect vitamin D absorption and result in and contribute to reduced bone mineral density. And this slide here shows the sort of problem we're dealing with. This is an individual with a fracture of their femur, and you can see that this is a very long, very thin bone and immobilized in a cast here. So it's very important for us to optimize conditions for achieving peak bone mass during childhood, especially during puberty, when we accumulate 40 to 50% of our bone mineral content in young people with cerebral palsy. So how are we going to manage puberty? Well, physically, we need to treat both precocious and delayed puberty and manage low bone mineral density, personal and social, the management of menstruation, sexual function, and contraceptive issues. So treatment of central precocious puberty, this seems a reasonable thing to do, especially in those who are very young. We're using long-acting GnRH agonists, including leuprorelin, triptorelin, and what these do is they cause initial stimulation of the receptor followed by blockage. So they arrest pubertal progress. They're generally well tolerated, but they have to be given by injection, usually every 3 to 6 months. But because they're completely arresting pubertal progress, they're associated with the reduced bone mineral density, such as would be occurring during normal prepubertal growth. What about treatment of delayed puberty? Again, really important that this is pursued. And we're inducing puberty using estrogen or testosterone in small incremental doses, aiming to mimic the tempo of normal puberty. If true puberty kicks in, then we can discontinue treatment. Otherwise, we will take that individual right the way through puberty to being ready to start on adult hormone replacement if needed. So management of low bone mineral density, correcting estrogen and testosterone deficiency, really, really important. Optimizing nutrition, including vitamin D and calcium supplements. We can usually manage the vitamin D and calcium supplements. Really correcting and optimizing nutrition can be really challenging. And then replacement of growth hormone in those who are found to be growth hormone deficiency. Bisphosphonate treatment, try not to use that, but obviously we may need to. Permidronate therapy is probably the most tried and tested in childhood and adolescence. And other approaches is physical therapy, trying to get these individuals to stand to weight bear, so those on standing frames, and also perhaps the vibrating platform to stimulate more of the bone muscle unit interaction. So now I want to just move on to some of the social aspects of puberty in those with cerebral palsy. So in girls, one of the fears for parents is menstruation. So these girls having to go through puberty, reach their menarche, and start their menstrual periods. And there are some indications for intervening in this process. And one of these is that girls with difficult epilepsy often experience a deterioration in their seizure control around the time of menstruation, and this can be really marked and difficult to manage. Difficulties with hygiene. This is both for the girls with cerebral palsy themselves. They can't manage their menstrual periods themselves, but they're very embarrassed and feel awkward about others helping them with this particular function. And their carers can also feel slightly awkward about this necessity. That's not to say we should be intervening, but it's something to bear in mind. And then perhaps much more importantly is painful, heavy periods, these girls going through all these difficulties and having a perceived reduction in their quality of life, recognizing that these girls are probably not going to have pregnancies themselves and that their life expectancy may well be significantly shorter than their healthy peers. What's really important, though, is to allow pubertal development to be completed. So I see many parents coming, we don't want her to go through puberty. What can you do to stop it? And we have to say they need to go through puberty. They need to develop, we need to be allowing them to accrue that critical bone mineralization that occurs during puberty. And then, so therefore, this is very much a wait and see phase. Get through puberty, reach menarche, and then just see how is it. And a lot of these families who are worried about this process, when it actually occurs, they manage very well, without pain, without it being a major disruption. A lot of these young people require nappies for a urinary and bowel incontinence anyway. But what possible options do we have for intervention? We have oral progestogens, the extended use of the oral contraceptive pill, the progestogen releasing intrauterine device, and I put surgical options in brackets. Just a little bit about those. If we're using oral progestogens, these are given continuously. They suppress the development of the endometrium, the endometrial lining. Possible agents are medroxyprogesterone or norethistérone. These girls may get some bleeding, but it's usually slight. But there are some side effects, mood changes, some increased risk of venous thromboembolism, and they do reduce estrogen levels to a small extent. In red, because we need to avoid the use of Depo-Provera. So these 3-monthly Depo-Progesterone are implicated in reducing bone mineral density, even in normal girls. So they really, although they may be very convenient, they are certainly not ideal for girls with cerebral palsy who are at great risk of reduced bone mineral density. The oral contraceptive pill, this is given in a number of different ways, perhaps for 9 weeks continuously. So that would be 3 packs back to back, and then a pill-free week to allow a withdrawal bleed. And what this does, it allows fewer menstrual periods. It gives control over their timing, and it can be good for those girls who have a deterioration in their seizure control at the time of menstruation. In fact, you can go even further than this. You can give the OCP continuously, and then when you have a breakthrough bleed, you can stop them for 4 or 5 days. However, there is an interaction between the OCP and some anticonvulsants, although it tends to be an effect on the OCP efficacy rather than the effect on the anticonvulsants themselves. But one needs to be aware. But if that's a major problem, there are transdermal contraceptive patches. Side effects, thromboembolism, and a slight increase in risk of carcinoma of the breast and cervix. But these side effects are generally small. What about the levonorgestrel releasing intrauterine device? They sit in the intrauterine cavity, and progestogen is released over about 5 years. And they stop menstrual periods completely in about 50% of healthy women. Side effects are rare, but breakthrough bleeding and infection, and they often give rise to some crampy abdominal pain after insertion. In this group, they would need inserting under a general anaesthetic, and we have to remember that those with moderate to severe cerebral palsy will be at an increased general anaesthetic risk. So although this works very well once it's in situ, it is much more difficult to put in place. Surgical options, endometrial ablation, where you're just basically removing that layer, or hysterectomy. But you can see that there are a number of ethical and legal difficulties, although in some cases it may be considered as a last resort. So this is a really difficult area. There's no perfect strategy. Allowing girls to complete their pubertal development is essential. The other options have different indications and side effect profile. But the most important consideration is bone mineral density. It's miserable for these girls if they start to have pathological fractures, and more studies are clearly needed. And then finally, really just talking about sexual maturation, and really the desire for sexual relationships is not always recognised in this group of vulnerable young people. I think this is changing, and those with cerebral palsy now have a voice, and they are making it very clear that, okay, their ability for a normal sexual relationship may be more difficult, but it is still something that the desire is there. And then contraception may be indicated to protect girls, mainly those with additional learning difficulties from unwanted pregnancies. That's not meant to say that, these girls who are clearly subject to potential sexual abuse should just be given the pill. They need to be protected from that. But some of these girls are quite precocious, all right, that they are perhaps, and encouraging attention from boys, and therefore run into problems. So in summary then, children with cerebral palsy are at risk of having abnormal linear growth and puberty compared with their normal peers. They're at risk of having low bone mineral density with pathological fractures, and timely complete pubertal development is needed to optimize the effect of sex steroids on bone mineral accrual. Puberty can give rise to practical issues, as we've seen, and sexual maturation and the desire for sexual relationships is not always recognized in this group of vulnerable young people. And thank you very much for listening, and I'm happy to take any questions.
Thank you, Debbie, for that.
I'm just going to try and stop. Sorry, I'm just trying to stop sharing. Let's go to there. Stop sharing.
Thank you, Debbie. You can cross your microphone so that I finish asking the question.
Okay.
Thank you, Debbie, for your nice presentation. We have really understood it. It's a topic that we have not addressed for many years. And I think this is an area that we need to do studies on so that we can see where we are with our children with cerebral palsy. There are some questions that have been asked in the screen, and there are different people asking different questions. The first question somebody is asking, I don't know how much study has been done in UK to check the cause of cerebral palsy. I'll ask you 3 questions at the same time, then you can answer them, and then after that I'm going to ask you you can write down the questions. In UK, have you done studies to try and see what is the cause of cerebral palsy? In our setup, it's not very clear. I will ask 3 questions, and then you can answer them after I have asked the 3 questions.
Yeah, better answer them at the time, if I may do, Lucy, because otherwise you'll have to repeat the questions.
Okay.
So in terms of that, yes, there are studies that have been done to see the causes of cerebral palsy. I get involved with growth and puberty problems, but they are there, but I am not familiar with the literature on them.
Okay, because in our setup, it's not very clear, but we know that quite a number of our patients that we see with cerebral palsy, there is infection and birth trauma as the main cause of cerebral palsy in our setup. But I haven't come across a study talking about checking and looking at these patients to see what could be happening to them. I think there are many things that we we have not done. The fact that we don't screen for inborn errors or metabolism is also a weakness on our side. So we don't know about genetic problems that these children could be having that we label them as cerebral palsy. And maybe there's something that you could have done before to try and stop and prevent the cerebral palsy that they have. So the other question.
Okay, I was just going to say, I think the difference here is that with cerebral palsy, when you talk about inborn errors of metabolism, you're often seeing progressive changes, whereas those with cerebral palsy, it's a very stable, static condition. So although you may start to develop your contractures, etc., you know, the actual neurological insult is entirely stable. So they are a special group. This is an insult that has occurred at a particular time. It may be over a period of time, but then it halts and it does not progress.
So the other question somebody is asking, saying that they have a 6-year-old who was found, I have a child who is turning 6 years this year. She was well until last year, 2023, when she developed abnormal movement, walking like she's staggering. On taking her for head MRI, she was found to have severe cerebral atrophy. Can this be, I think it is this cerebral palsy, or this something that is reversible? I think this is more of a neurological problem rather than.
I think that, yeah. I think, you know, that, so the child that I presented who had some minor changes with just dragging his left foot or his right foot, he had some minor changes. So if you've got a child who was entirely normal developmentally, and then you have a regression and problems, then I think you're looking at a new cerebral insult, not necessarily completely new, but that cerebral atrophy is unlikely to have been present right from, you know, often these are before, you know, these are prenatal insults.
The other question that is here is on whether we have growth hormone locally. And I can answer that. We have growth hormone that is, before the Novo was importing the growth hormone for us, but they are not doing it currently. But there are some parallel imports that are available. Roughly, the cost is between 30 and 35,000 per month. That's the dose of growth hormone for these patients. What I wanted to ask Debbie, these patients with cerebral palsy, when they don't have growth hormone, when you give them the growth hormone, does the brain grow, or only the skeletal and muscle that grow?
Well, they're going to respond to the growth hormone. I mean, it's not a major factor in brain growth. You're not going to improve their cerebral palsy as such. As I say, that's a very static lesion. But all the other effects, so, you know, in a way, we use the growth as a surrogate marker of their response. But as you will be very aware, there are many metabolic effects of growth hormone, improving quality of life, improving muscle strength. So that certainly can be helpful, but improving cardiovascular health, vascular health. So yes, I mean, it's everything. So it's not particularly increasing brain growth as such. It's not one of the, I mean, obviously you can get local growth factors. I don't think that growth hormone is really, you know, one of them either. So no, it's not going to make a difference to brain growth.
Somebody is asking about the giving external hormone, giving testosterone or giving estrogen. How would you tell that the difference between induced puberty and physiologic puberty? There are tests that we usually do, which if you remember the physiology in second year, in undergraduate of LH and FSH, estrogen, testosterone, that helps you to know whether the problem, what we have, the puberty you have is not what we call central precocious puberty, or it could be the child could be having another abnormality. So if LH and FSH are high, and you have that estrogen and testosterone are high, and then you do a brain MRI, and the brain MRI is normal, then most likely you are having a physiological puberty in this case. But if the patient has low LH, low FSH, and then high testosterone, high estrogen, then those hormones must be coming from somewhere else, but not directed by the hypothalamus and the pituitary. And that's what you usually look for. And there is somebody here asking whether is it recommended that we do DEXA studies on this patient with cerebral palsy regularly? How often do you do in your clinic?
Well, I would say that we don't do them regularly, because, you know, actually scanning some of these individuals is very complex. Really, so we would do a baseline, and then maybe every 3 to 5 years, depending on, whether they are, obviously whether they're having any fractures. As soon as they have a fracture, then that makes a difference. We also have to remember that, we've got a weak, the spine is also potentially affected. Some of these individuals, they've got scoliosis, so actually interpreting some of these scans is really tricky. So yes, DEXA scan, we do, but not that frequently.
The other question is, I think this can be answered by a hematologist. I don't know whether we have a hematologist in the group asking why these patients have frequent anemia despite good diet and treatment. That can be answered by the hematologist in the group who is with us. And then there is this famous anonymous attendee. I have no idea who the anonymous attendee is. There is a new trend of I think this question is keeping on coming about transgender and LGBTQ. That one I'm going to leave.
That's okay. I'm happy to. So if we're thinking of things like pubertal induction,
No,
right?
Prof, doc, just leave it for the time being, and
Okay.
because just leave it for the time being. Just leave the question for the time being.
Okay.
What is the effect of Depo-Provera in bone mass density? I think we were told it's going to reduce the density of the bone. And then the other question is, how long should the CP patient take calcium and vitamin D, since we know the bone mass density can be a long time issue?
We're going to continue.
Yeah, the thing is, you have to assess the vitamin D in this patient and check the calcium, because sometimes we give calcium too much, sometimes too much calcium and too much vitamin D, and sometimes we find the child is almost calcifying every tissue in the body. So we need to analyze the vitamin D as you give it, as you follow the patient for bone mass density. And then
I would just like to say as well that one of, potentially one of the factors causing hypercalcemia will be the immobilization that these patients. So it's not just about your vitamin D and calcium supplements. But that obviously, if you're immobilized, that's mobilizing calcium from your skeleton. So, it's quite a complex area, and how you monitor it, with a straightforward, whether you're measuring vitamin D and calcium, you probably need to look at rather more than that on a less frequent basis. We're not talking of giving big doses. We're talking of giving appropriate doses to make sure that we're giving enough, because so many will not have enough dietary calcium or dietary, or vitamin D. They don't see sunlight either, so they're not very good. They spend more of their time indoors than their healthy peers.
About induction of puberty in our setup, I think most parents, they want a child they can lift and take outside. They can go with the child, take the child from the bed. They are actually not so much interested in having a big child, actually, when
I
the
know.
children.
Yeah.
And also they are in our setup, they are not very eager to have the children go through they won't do artificial induction of puberty. They are happy with the child not going through puberty because of the implication in our setup. So there's somebody who is asking whether if you find the child has been stressed, I don't know, you are saying that could psychological intervention help reduce delay on onset of puberty? Any studies checking on whether if you remove the stress, what is stressing the child, whether the puberty will occur? We know that there are studies that have been done on children who are adopted, like from Africa and Asia. When they go to Europe, they quickly get a precocious or accelerated puberty because of sudden increase of food and actually the stressful situation they have been, they quickly go into puberty. But about cerebral palsy and I don't know whether I don't think we have any studies checking about cerebral palsy and puberty.
I mean, I think can I just make a comment?
Yes.
Is the issue around puberty that's why I made the point that, it's not in the interests of many parents of carers to have a large child. I would say that because of the abnormal bone muscle unit, as we've already said, a lot of these individuals never become particularly tall or particularly heavy. And the issue really is if they haven't gone through puberty, they haven't had exposure to sex steroids, then moving them around, lifting them, carrying can be enough just to cause that fracture. So although it may seem ideal, you're actually going to run into more problems with pathological fractures because they have no sex steroid. They've never been exposed to sex steroid. So I think it is really important that they do go through puberty. But I quite understand the reluctance and reticence of families to actually allow this.
Somebody is commenting about that. Is Dixon is talking about dental caries and cerebral palsy patients, and she's asking, could this be due to poor bone mineralization in these patients, the dental caries in these patients?
Yes, I mean, I think again, it's going to be multifactorial, as is the case with so much of this. So, so poor mineralization. So obviously that's going to affect the teeth, but there's also about dental hygiene and the ability to be able to clean the teeth. These young people, they're probably unable to clean their own teeth. And a lot of them will have, spasticity affecting their jaw, so they can't open their mouth properly. They can't comply, they've got abnormal tongue movements. So actually achieving good dental hygiene is really important, is really difficult. And then going to the dentist, having dental care, having, your cavities filled before, again, is extremely difficult. So unfortunately, there are so many factors which make life with moderate to severe cerebral palsy difficult. And I think really what I wanted to highlight was that there is a role of endocrinology and endocrinopathies here, and just recognizing them and thinking how we should be managing them and looking for them.
There's somebody who is saying that they have Annabelle is saying that they have been having a person with cerebral palsy, and up to the age of 18 he had stopped. From the age of 18 he had stopped passing urine in bed, but now since the age of 25 started having the problem of passing urine. I think the whole thing need to be analyzed and check who are the caretakers taking care of this patient, because sometimes we know, and we have seen it even in other countries, that people who are not able to communicate very well, like people with dementia, when they are left with the caretaker, sometimes they take advantage, and actually they can bully them and they can molest them. So somebody need to check on this young man to check what is happening in this patient. I don't think the passing of urine is an endocrine issue. I think it needs to be addressed from the psychological point of view so that somebody can assess and see. And Margaret, you're asking us to go through the management of precocious puberty. I think Debbie already explained to us about how to manage precocious puberty, the drug that we are. I think what you are going to do is to look at the audio, which is going to be in the Kenyatta Hospital website, and then you can listen to it, and then you can go through it, and then I don't think we will go back to it. And then with the bone changes explained, at what age do you recommend vitamin D and calcium supplement? This one is even during infancy. You have to check the levels of these patients and see when you should start, because you are looking at this child and you are looking at the vitamin D, you are checking calcium. These children are supposed to be taken to the sun. In Kenya, we are sun-flooded countries. They should get vitamin D in the sun, and it's more expensive to buy vitamin D than to take the child in the sun. So these children need to be taken to the sun. And when they are taken to the sun, they have vitamin D that is able to trap the calcium that is in the bone from the gut. So the sun will help quite a bit. And then after that, make sure that these children are maybe they are on taking bone soup, or they are taking milk, and they are taking cheese to try and get more, an egg to give them more source of calcium in this. Cerebral proteins beneficial in patients with cerebral palsy. I don't think we were trying to manage cerebral palsy in this case. We were talking about endocrine issues in patients with cerebral palsy. I don't think we will go into the management of cerebral palsy with cerebral proteins in this case. Then somebody is saying, when
I just wanted to. Sorry, I just wanted to say something about the sunlight. Absolutely right. That's ideal, and calcium in milk and what have you, great. But the natural history, and this may be different here, is that a lot more, children with cerebral palsy will spend more of their time indoors, because obviously when they're indoors, they can be probably kept safer than being outdoors. But obviously it depends on the environment that you're living in.
There's somebody, I think Professor Irimo is talking about this. If we should work hard to try and prevent cerebral palsy that can lead to we should work hard to prevent birth asphyxia that can lead to cerebral palsy in this patient in our setup, because we can see all the complications that can come in these patients. I think we should do more in this area. Then somebody here, Evelyn, is asking, thank you for the wonderful presentation. How can these students be protected from sexual exploitation, especially at puberty, because this is an issue, especially for the poor? Actually, I was just listening to Debbie talking, and I was thinking, in our setup, if somebody knows that these children are on contraceptives, they will be the predators for this sexual harassment.
They don't have to know.
Yeah.
They don't have to know, but it's
the main predators for these children are not outsiders; they are relatives within the house. They are the ones who are abusing children. So it's an area that is very controversial in our setup, and I don't think most people and parents will start putting the children on any of these contraceptives to prevent them from.
I agree.
What they will try and do is to.
Yeah. I agree. I'm not saying that it should be, a panacea, that this is the way forward. But I think it's the vulnerable girls who are very precocious, who are outside, that probably it's not so much these moderate to severe cerebral palsy patients. It's more those with learning difficulties. So I accept that, that they are less likely to actually need that sort of to be started on contraception, because it's not that they are going to be going out themselves and perhaps getting into trouble. As you say, it's going to happen more by those who know them. But it is, I think, very important.
The same anonymous attendee is accurate. He not letting go the area of the inguinal area. Is still asking. I have an experience with a 13-year-old who gets painful erections that goes flaccid only after defecation, as reported by mother, and it has been assumed to be the normal fashion in normal boys for close to 2 years. And such issues, have you seen such kind of issues? I can tell you that there is a boy we had who was referred to us with the priapism, and they thought it was an hormonal issue. So what we did before we did most of these things, we sent the patient for EEG, and actually it was found it was conversions. The child had conversions, and that's why they were having the priapism was a form of conversions. This child needs to be investigated to know whether what is happening, whether it is endocrine, and check the hormonal levels in this patient so that they can see what is happening. Let me go to the next question. What causes cerebral palsy in adult? We don't have cerebral palsy coming in adult life, and epilepsy after puberty. Maybe talking about puberty and cerebral, talking about epilepsy after puberty, this can be addressed by a neurologist. I don't think Debbie will be able to answer this question there's somebody else. What is the dose of this growth hormone you have just mentioned? That one you just have to discuss with the endocrinologist depending on the body surface area of the patient. Then you can see whether the patient requires the growth hormone or not, because it's not something that is just given to everybody. And then Joshua, I heard of you talking of Mirena, and can it be used to control menorrhagia? In our setup, I don't know menorrhagia in who, because we are talking about children in this case, and I don't think we are going to talk about Mirena being used in our children. You have heard about the process of inserting it in a child. So I don't think we are going to talk about it. This one actually can be addressed by a gynecology about menorrhagia maybe in adults. I don't think if it's a child who has menorrhagia, we will do the hormonal analysis in this patient. You do the ultrasound, you do the MRI, and we check what is happening in this child. But you want to add something, Debbie?
I was just going to say that, it is something certainly that we do see, because if you think about girls, that not necessarily with cerebral palsy, but we can have them, they complete puberty by the age of 11, and then they can have menorrhagia. So as pediatricians, it's something that we do need to be able to manage in certain. I've been very lucky to do a joint clinic with an interested gynecologist, so we could address some of these issues. I didn't hear what the question was about. I'm happy to try and answer it, but I didn't hear what the question was. But if you just want to move on, I'm happy either way. But I'm also it is something that we do manage. Yeah.
They're talking about the treatment for menorrhagia, and this is what I was saying. We need. I don't think it is in a child. They are talking about it in an adult, how to manage menorrhagia. And then somebody is talking about a child 2 years walking on 4, hasn't walked. How can you help? And what is the diagnosis? You need to refer the patient through, either if you want the child to come to Kenyatta, you refer the patient to go to the neurologist, and we have the clinic on the same day. The child can be seen by the neurologist, and it can be seen by the endocrinologist on the same day, because it is hard for us to make a diagnosis by the one sentence that you have sent us. And then what are some of the key considerations for CP management in the rural setup? I think we were only addressing the endocrine setting, and if you want the child to be assessed for endocrine setting, the child can be seen by a pediatrician who is nearest you, who can assess the child and can see whether the child needs to be referred to Kenyatta or not. Are there organizations that support cerebral palsy? I think there is a cerebral palsy organization in Kenya. Just Google it. I think we have cerebral palsy, a group that is taking care of this patient. I think there is. what happened in a CP child who is born with undecided testes 4 years now? If the parents want, they can send the patient for analysis to check actually whether the child is a boy or a girl, because every time we don't have testes down in a child, we are not sure whether the child is a boy or a girl. The child needs to be analyzed, and then we see what need, whether the child can be taken to the pediatric surgery, pediatric surgeon to see whether they can, what other tests they need. Before any surgery in a child with undecided testes, you usually do laparoscopy to try and check whether they can see the gonads in the abdomen. So there are a few things that we work as a team with the pediatric surgeons. The other question, we should avoid issuing depot as a family planning method as such. I think what you need to do, Samuel, is you check online all the side effects of depot. On top of that, checking the accumulation of water in the brain, and also the reduced libido in women and the issues in the family. Just check on these things online. They are there and they are available. There are studies on the role of other counter-regulatory hormone in precocious puberty and CP. All the precocious puberty, but either CP or ordinary children with precocious puberty, they are all treated the same, and it's the same medication that they are given. That medication is not cheap. They are usually given, it's given once a month. It's an injection they get once a month, and the cost is between 7,000 to 11,000 per month. Yeah, there is somebody who is saying, Lucy, just read the question and allow Debbie to answer. The reason why I'm going, because the questions are very many and Debbie will not be able to answer. So I can jump some of the questions so that we address the endocrine ones. The ones that are neurology, we are not going to, or any others. That I'm the gatekeeper for these questions. Hello, doctor. I want to ask, what is the best way to support emotional teenage children with the CP? We are dealing with endocrine issues today. So in terms of emotional, what we need to do is we see whether we can get a psychologist near at us who can help to support and address the issues that are emotional. But in terms of endocrine, we can really support you. I don't know what, Debbie, you can say about that.
Yeah, I think I was going to say that I think, they do lead a completely holistic approach. Yeah. And all of us, all of the professionals involved, need to be cognizant of the fact that these individuals, as adolescents, they're just not able to develop in the way that their normal peers do, and that needs addressing. So having a psychologist, I agree with you, is absolutely, is what you need. But that psychologist also needs to be very aware of what the issues are that these young people are facing, because otherwise they may not have the full understanding. They're likely to be they're likely to know, because cerebral palsy, unfortunately, is really quite common.
There's a question that has been written here. Jeffrey, I can't read your question. There's something I can't check. I don't know what is the levels that you ask. Is it vitamin D levels? The problem with resource poor setting is that we don't have vitamin D levels available. It is available. Kenyatta is doing the vitamin D levels. If you want to send the sample, it can be done, but also it is not cheap, but it can be done in Kenyatta. What calcium supplement should we give to adults above 18 years? Do you deal with patients above 18 years, Debbie?
No, not generally. No, just those, cancer patients, but that's
my understanding now is that minority CP clients could be because of bone density, hence low weight. How do we correct bone density in Kenya? I think Debbie addressed that about bone density.
Yeah, I mean, well, bone density. So if you're looking at DEXA scans, then in order to get valid measurements, you need to have the software from your scanner, which will make the adjustments according to body size and bone size as well. And I can certainly think of a number of cases whereby even young adults who are particularly small have been told that they have severe osteoporosis, but they didn't. They just hadn't had that adjustment made. So I think that's a good question. That's absolutely critical, that a DEXA scan, the information needs to be adjusted according to the size of the individual.
But the other thing is to remember that in our setup, DEX studies are not readily available for our patients.
Well, we don't use them that much in children. We do use them, but it's certainly not one that we would be doing on a regular basis at all. It's often at baseline and then a few years following some intervention, unless there is a major problem. We may do them more frequently if we're expecting rapid bone mineral accrual. So, for example, we might, before and at the end of puberty, but most of the time we wouldn't do it before puberty. We'd know that this is going to be on the low side, and we wouldn't do it until they've, this is on pubertal induction, that we wouldn't do it until they've actually completed that process.
There is somebody here, Eddie. I agree with you that we need a topic on cerebral palsy and mental status in this group of patients. I think we need to organize a webinar for cerebral palsy and the mental issues that they usually have. Somebody needs to give us a topic, a presentation on this. Somebody is saying that Kenyatta has not uploaded the webinars from the Kenyatta has not uploaded the webinars. I think the administrator in this meeting can hear. There is somebody here called Wagari as a senior registrar pediatric dentistry, contributing on the question of caries and CP, as the presenter has clarified. Caries is multifactorial. However, some studies have shown that these children may present with a higher incidence of enamel defect, which further increases the caries risk, which possibly may have a causal relationship with vitamin D and calcium metabolism, as proper mineralization of enamel is dependent on optimum vitamin D and calcium metabolism. Thanks for the enlightening presentation. Wangari, thank you for that comment. Is there active group to support? I think that one I had answered. And then that one had been answered. And then what is the other question? Anemia, I think I addressed that. I have a 5-year-old girl, unable to walk, but understanding things, unable to talk, but not clear. I noticed that she reacts like someone feeling pain when I'm cleaning her private part. What can be the problem? I don't know who is this, and I don't know who is this anonymous attendee, so that I tell you exactly what is happening. Remember that the private parts of girl is very, very sensitive. It depends on how much you rub that area. So talking about whether it's painful or not, somebody needs to check how it be. Sometimes it's good to use cotton wool to clean that area, especially for the young girl, or something, a flannel that is very soft for them. In terms of, I would like you people to check on Team Hoyt. Hoyt is H-O-Y-T. H-O-Y-T. Team is T-E-A-M. Team Hoyt is he's a man. I think now he's about 60 years. He was running with his father, and he has always had cerebral palsy. And the parents discovered he could understand many things, and he did a degree using the computer, but he was using the eyelid to move the mouse, a technology which we are not reached there. And then they were able to put a chip in his brain, and he's able to talk through the computer. I think somebody should check that, because it doesn't mean we need to enter into the life of cerebral palsy patients, and the neurosurgeon need to help us. that we can see what is, if they're able to talk through the computer, then we should be able to understand them. What is the management of gigantism in cerebral palsy in a teen child whose only biochemical anomalies are lack of testosterone, LH, and FSH? Doc, do you want to answer that question?
I didn't, sorry, what is the cause of what? Gigantism?
Gigantism in cerebral palsy, and the only thing that is abnormal in this patient is lack of testosterone, LH, and FSH.
Gigantism, that would be very unusual. Obviously, if you've not if they've not got any testosterone around, how old is this child?
They have not mentioned the age.
They haven't mentioned. I mean, if they're pubertal age, then obviously they haven't gone through puberty. They could have, multiple pituitary hormone deficiency. They can have hypogonadotrophic hypogonadism, which would obviously go along with that. And those individuals, unlike those with constitutional delay in growth and puberty, tend to be taller and they will continue to grow. So, but not gigantic, not gigantism, which is obviously suggestive of an overproduction. It depends a little bit on what their parental height was, just really what we're talking about in terms of height. But that would be my first thought, is hypogonadotrophic hypogonadism in a child who should have gone through puberty, who hasn't, who is still relatively tall or is tall, or genetic problem. It's very hard just with that amount of information. So you would need to clarify rather more.
Thank you so much, Dr. Matthews and Dr. Lucy, for this incredible topic. I have learned a lot. Thank you so much. God bless you. Matthews, you have heard Debbie. There are some questions here I'm going to omit because I think we had addressed them. And somebody is asking whether cerebral palsy is reversible, and we are told it is not reversible. If it was, actually, we would not be talking about it today. If it was,
it is irreversible, yes.
Yeah. Yeah, there is somebody saying there is a Cerebral Palsy Foundation Center in Mombasa for those asking for help. Please contact Andy Omtere. Then there's somebody, people are talking about their points, and people are talking about, I think we have, I just wanted to clarify just one more thing, because I think I have done all the questions that are in the group. There's something that I wanted the people who are present to understand about you mentioned every time you are checking for precocious puberty, in your result, you always indicate prolactin and thyroid function test. It looks like there is something you want, there's a message you want to give us about puberty, thyroid hormone, and prolactin. Do you want to elaborate the relationship between the three?
Who, for me? Sorry,
Yes.
We've got prolactin, thyroid function, and liver function. What was the other one? Sorry?
I said, whenever we have a patient with issues of puberty, you seem all the time to put the result of thyroid function test and prolactin. Is there any the message you want to tell us?
I think really because, well, particularly prolactin. So, the hyperprolactinemia is rare in children. It's really common in adults. And it is a potent cause of delayed puberty, and will give you a hypogonadotrophic hypogonadism picture. And thyroid function tests, obviously abnormal thyroid function, will also impact on pubertal onset and progress. So again, it's important to remove that. And then liver function tests, was that the other one? It was
thyroid function. test.
Yeah,
The
so
sex hormone.
thyroid function test and prolactin. It's because both of them can impact on the onset of puberty and the progress of puberty, menstruation. So in all sorts of different ways. So if you think of, you know, profound hypothyroidism, you can get cysts in girls, you can get bleeding in girls who haven't gone through puberty, you can get macroorchidism, so boys who appear to be well on in puberty but no other signs. So that's just an example. And prolactin, if we don't measure it, we won't know, you know, exactly what and it's very easy to miss. And yes, it is uncommon, but we certainly do see it.
So every time we have a child with the problem of puberty, we are supposed to check prolactin and thyroid function test.
It depends on the clinical picture. And it depends. So you wouldn't, you know, you're really looking at, so prolactin, for example, will really only be a possible issue if you've got low gonadotropins, that, you know, that puberty hasn't started from those higher, so from the hypothalamus and above or beyond. So it's that sort of issue. So you really need to have teased out where that problem is. But it certainly is. So if you've got gonadotropins there, but you're not producing estrogen or testosterone, then that's nothing to do with prolactin. You don't need to measure it, but it would certainly be part of your screen if you had, you know, low gonadotropins. And I know that, you know, cost of investigations is very much a feature, but you will find that your adult colleagues will measure prolactin very frequently, I'm sure.
Okay, thank you, Debbie. We have gone through about 65 questions that had been put. I have jumped a few. I've been accused of not reading all of them or answering some, so that I can protect you from answering the 65. But we have managed to go through them. Dixon, Dr. Wangari Dixon is very happy you have answered her question, and there are some people from Uganda who want CPD points and sent to Uganda. We have to see how to liaise with the medical board in Uganda. I don't know whether Kenyatta team are able to send to the medical board in Uganda. We are very, very grateful. It's now 8:28. I would like to thank you very much, Dr. Debbie. You are leaving Kenya in the next 2 days, and we are very grateful. You have been so helpful in our department and also in giving this talk. Thank you very much. We are very,
Thank you very much.
Thank you very much.
Thank you very much. Thank you.
I offer to the team from Kenyatta. Is there anything you want to talk about the CBD points? Kenyatta team, anything about CBD point?
As stated earlier during the housekeeping rules, if you do have queries on CPD, kindly send them through knhcpd@gmail.com. That way we can be able to check our records and give you the correct feedback that you need. So kindly channel them through knhcpd@gmail.com and you will be able to be assisted.
Thank you very much.
Okay. So thank you all for joining us today. We will be back next week on Wednesday, and that the session will be on pain, the start of the pain management series, and we'll be looking at pain assessment. So kindly do be keen on the notifications that we'll be sending out on this, and kindly join us for that session. Thank you once again, and have a wonderful evening. Goodbye.